My pleasure as Executive Director of the Pink House, Carolina Breast Friends, to welcome and introduce Dr. Richard White, who is the Chief of Surgical Oncology at Levine Cancer Institute here in Charlotte, and also the co-director of Levine's melanoma and breast programs. Thank you so much, Dr. White, for being with us and sharing your expertise with Carolina Breast Friends and all of the survivors. I'll turn it over to you.
Yeah, and as many of you know, or maybe you don't know, Christy, who founded Carolina's Breast Friend, was my patient.
Yes.
And I really encouraged her over the years to get involved, and frankly, she's built a great program. You guys have inherited a terrific program over the years. Now I'm going to go through a lot of things very quickly. I'm going to try and stick to the time and leave about 15 minutes at the end. But I think it's important to understand sort of basics. What I've called this talk is breast cancer, what's new, what works, and what matters. There are a lot of things out there in the lay press, which is one of the reasons I started with a Time magazine thing. But we're going to talk about some really constants that I see in my clinic all the time. Things like, do I need a mastectomy? Is mastectomy better? And it turns out the answer is no, it's not. Do I need to remove the other breast? The answer is no, you don't. Do I need a breast MR? The answer is no, but it is reasonable in some high-risk screening scenarios. What about this preoperative chemotherapy stuff? And we'll talk a little bit about that. We'll talk about genomic testing, which has actually radically taken over what we've done. We'll touch briefly upon genetic testing, risk reduction. I probably won't spend much time on axillary dissection because we just will run out of time. Biologics, and really what's new will be my last slide. So what's the scope of the problem? One of the questions that I got asked when I was a initiating fellow at the National Cancer Institute, I won't tell you when that was, but it was some time ago, how many cancers are there in the United States every year? And the funny thing was, all these bright-eyed fellows, almost none of them knew the answer to it. And right now there's about 1.8 million cancer cases in the United States every year, and about 600,000 deaths. What does that mean? Well, there's about 5,000 new cases a day and about 1,600 deaths every day. Now, this is a remarkable slide. Actually, this is the incidence. In other words, the likelihood of getting cancer at any given time. Unfortunately, lung and bronchus has continued to increase, but you can see breast cancer rates have somewhat flattened out over the years. But I want you to take a good look at the mortality rates in breast cancer, and we're going to see a more updated one here. This is trends in death rates in women's cancers. And one of the great achievements of our society over the last 10 to 20 years is what's happened with lung cancer. You see these lung cancer deaths dropping like a stone. The other thing I would point out is look at the breast cancer death rates and how they've dropped dramatically. Here's colorectal cancer death rates. This is really a testament to all the work that many people have put in over the years, and really something very heartwarming to those of us who take care of cancer patients. And again, I want to point out a little more colorful graph. Look what's happened to breast cancer death rates over the years. It's been quite astounding. So what's the scope of breast cancer care or breast cancer in the United States? This coming year, there's going to be almost 280,000 women diagnosed with breast cancer and about 42,000 deaths. In North Carolina alone, that means about 9,340 new diagnoses and about 1,440 deaths. I would say that we at Atrium in the metropolitan area take care of about 22% of all the breast cancer in North Carolina every year. We take care of about 1,500, 1,600 new patients every year through Atrium in the metropolitan area. So we talked a little bit about the incidence rates. It took a dip in 2000, 2005, and it sort of flattened out. This is the likelihood of getting breast cancer. And once again, the death rates have really dropped very nicely, something that we should all be proud of. And you can see that these death rates have translated to white, black, Indian Americans, and African Americans as well. Another way to put this is the survival rates have really increased. Certainly they've increased disproportionately, and there are some obvious disparities we need to address. I won't go into that today. This also translated in trends of 5-year survival in breast cancer. And when we get to the end, we're going to talk about sort of dialing back on some of the interventions we've done, because as you can see, right now, if you're a postmenopausal woman getting mammograms on a regular basis, your 5-year survival rate exceeds 90%. And you can see the survival by stage. This is a 5-year breast cancer specific survival, and here's localized breast cancer in various populations, but you can see these numbers are all in their 90s. Regional, generally meaning lymph nodes are involved, distant disease. So one of the issues that interestingly continues to come up, although it's really a settled issue scientifically, is it better to have a mastectomy versus a lumpectomy and radiation therapy? And this actually was asked in one of these first studies. And that's why this question dates back to the 1970s. And this trial, called the NSABP B06 trial, randomized 2,100 women, flipped a coin. Were you going to have a mastectomy or a lumpectomy and radiation therapy? And lo and behold, these women were very generous and actually volunteered to be in this study. And they either got total mastectomy, a lumpectomy without radiation, or a lumpectomy plus radiation. By the way, another term for lumpectomy is segmental mastectomy or partial mastectomy. So if you hear that word, don't flip. That just means exactly what it says, removal of a portion of the breast. And these are results now with 20 years of follow-up. And by the way, this is published a number of years ago. And you can see there's absolutely no difference in what's called disease-free survival, which is a nice way of saying walking around without breast cancer. Distant disease-free survival, in other words, not just in the breast and the lymph nodes, but elsewhere in the body, and overall survival. So there's absolutely no difference between having a lumpectomy or a mastectomy or lumpectomy and radiation therapy. What the radiation therapy does is reduces the risk of local recurrence. We'll get to that a little bit, local recurrence meaning in the breast or the lymph nodes. But make no mistake, there have been 6 different studies on 5 different continents that asked exactly the same question, and there is no benefit in terms of survival to a mastectomy. This is nicely stated. I actually use this quote in my notes regarding the patients I see in the office. 6 modern prospective randomized, those are the best ones you can possibly do, where you take women and you randomize them at the very beginning, have demonstrated that breast conserving therapy, lumpectomy followed by radiation, offers survival rates equivalent to mastectomy. If negative margins are achieved and radiation given, local recurrence rates are equivalent. So there's really no reason in this day and age that one would have to do a mastectomy, with several exceptions. One, if you have a genetic mutation where we're concerned about your risk of it coming back on that breast is substantially higher than the rest of the, as usual. If you have a large tumor and a small breast, that's a reason. But most of the reasons have to do with either risk factors or the inability to obtain good margins, in other words, getting all the way around the tumor without and leaving a good cosmetic result. Well, why is this? Well, what I always remind patients, why wouldn't a mastectomy be better? Well, a lot of women actually think that the breast is actually like an orange. If you can see me on the screen, imagine the orange, and the orange peel is the skin. Well, if you throw away the rotten orange, it should be all good, right? Well, that's not correct. You can see from this anatomical drawing that the breast tissue actually abuts the skin in many places here. So if you leave any of the skin, and we're not talking about doing mastectomies like they did in 1895, where they actually removed all of the skin. Anytime you do a mastectomy and leave any skin behind, we know we leave some breast tissue behind. But probably more importantly, if you look at this picture down here, you can see these malignant tumors are in fact cancer because they don't respect the anatomic boundaries. So even if it was sort of the orange and the orange peel, the problem is that the cancer cells don't care about that. They'll show up in the skin. They'll show up in fat that's nowhere near the breast tissue. They'll show up in the muscle nearby. And that's why the local recurrence rates, in other words, coming back in the area around it, are essentially the same in modern series. And part of the issue also is a very good news story. You know, we just looked at our 5-year recurrence rate throughout the entire metropolitan area. And at 5 years, the local recurrence is 2%. My personal rate of risk of local recurrence is 1.8% over a 5-year time period. Well, it's hard to imagine that doing a mastectomy is going to drop that number substantially lower than 2%. So the good news is, just like colon cancer or a skin cancer or a lung cancer or almost any other solid tumor, you don't need to remove the entire organ. There was a fascinating New York Times article written by a woman with breast cancer who compared her breast to her ear and having a skin cancer on her ear. She wouldn't have considered removing her whole ear, although it would have been a very effective operation. So I often get asked about, well, the other breast, what should I do? I mean, my neighbor told me I should have both of them off. The risk of developing breast cancer on the opposite side is about 2.5 to 5% over a 10-year period of time. And then the question comes up, well, is there any longevity benefit? In other words, if I remove this breast, will I live any longer? And the answer is a definitive no. You won't live any longer. And that is this, no matter what age you are. And so this has been looked at a number, and I'm going to show you a number of quotes. This was actually from the American Society of Breast Surgeons, where the conclusion of the paper here was the majority of women will obtain no oncologic benefit from CPM as contralateral prophylactic mastectomy. That means removing the other side. And therefore, contralateral prophylactic mastectomy should be discouraged in average risk women with unilateral breast cancer. In other words, if you only have it on one side, you don't need it on the other side. This is actually from another source. One is scientific, one is the New York Times. The story didn't change, said Todd Tuttle. Todd's a friend of mine at the University of Minnesota. They created a study that was published in the Journal of the National Cancer Institute, where they actually took modeling and computer modeling and tried to figure out, could we find a group of women that might benefit by removing their other breast? And the answer was, even if we used unrealistic figures, the conclusions were still the same. There is no group with a survival benefit of even 1% for removing the other breast. Tara King, who's actually in Boston, they looked at it at high risk, even in our highest risk cohorts, young women. And she has a specific interest in young women, as we do. We're one of 5 programs in the country with a particular program for young women. There was no data that contralateral prophylactic mastectomy improved survival. Dr. King said that women are asked to choose why they choose contralateral prophylactic mastectomy. It's the most common answer is for peace of mind. They feel like they will worry less, have less anxiety, and feel better going forward in eliminating what they perceive as a big risk. We try to inform them that as their actual risk of developing breast cancer in that healthy breast over time, and the risk of developing their, related to their current cancer coming back is quite a bit higher than the risk of developing a new breast cancer. And further, she did a study of these women, and somewhere about a third of those women who chose bilateral mastectomy worried as much as they had before. So removing the breast actually wasn't going to help them worry less. It now gave them a whole set of problems related to their mastectomy, including implant reconstruction, chronic, what's called post-mastectomy pain syndrome, which is somewhere between 4 and 40% of women, all the things related to reconstruction. So there's really been a lot of work done on this, and I think you can see some of the conclusions. Why doesn't it benefit? Well, we already talked about the low risk of developing cancer in the opposite breast. Keep in mind, almost every woman with breast cancer is followed quite closely. And in those who do get a cancer on the other side, the cure rates exceed 90%. In fact, they're up around 92 to 93%. It's very hard to imagine how you would do better. Now, the other thing that comes up all the time now in my clinic is breast MRI. In the United States, for reasons that I sort of understand, we believe that whatever is new is better. So iPhone 12 is gonna have to be better than iPhone 10, which was gonna have to be better than iPhone 7. Now, as a guy who has an iPhone 7, I'll tell you, I'm not jumping on it, but my point being is that we believe that new technology is always better. It turns out in the vast majority of cancer situations, new stuff is not better. And in fact, most of the new stuff in breast cancer over the years has failed to show improvements. One of the reasons is because we're doing well. So breast MRI has been around almost for 20 years, and it's been touted as the greatest thing since sliced bread. And in fact, I think I'm going to borrow from one of my mentors. It's a great technology looking for a use. It is very, very sensitive for finding stuff in the breast. And this is actually one of its flaws because it finds so much stuff. There's a tremendous amount of what we call false positives, things that don't matter to the patient, but show up on the scan and are commented on the report, can look and sound very scary, but have nothing to do with how you're going to be treated. So for example, on this picture here, this is a breast cancer right here. But this is not, this is not, this is not, this is not, and this is not. So it's all very scary and sounds like there's things all over the breast, but in fact, they're not. So at least 16% of people who have a breast cancer and undergo a breast MRI have additional findings. The numbers are sometimes as high as 35%. And at least a third, and in some series up to 2/3 of these additional findings are completely benign and have nothing to do with the cancer. In addition, it can find stuff on the other side. The problem is the finding stuff on the other side has not been associated with improvement in anything. Now, it does allow assessment of both the anatomy of the breast and blood flow. So these big white lines you see here, those are blood vessels in the breast. The con is that it clearly leads to more extensive surgery. About 12% of women have more surgery done without any improvement in their outcomes. The other problem is that the mastectomy rates increase dramatically, and we're going to talk about that. So about 19% of people in this paper that was published in the Journal of Clinical Oncology have additional stuff done that is not of any use to them. Now, is there a role for screening MRI as an adjunct to mammography? Well, in women who have a greater than 20% lifetime risk of breast cancer, an MRI is a good idea. And we'll talk about that a little bit. But for most women, this is not in any way helpful. Now, who should get it? You know, if you have a mutation, yeah, you should get an MRI. If you have a first-degree relative, you should think about getting an MRI. If you have a lifetime risk of greater than 20%, you should get an MRI. Had radiation therapy. Now, the bottom line is that doesn't say get it if you have breast cancer. So a lot of people have said, well, we're going to stage the women so we get a better idea of what's in there, and we're going to reduce where the doctor comes along and gets what's called a positive margin. And in fact, if you look at all comers, the answer is no, it doesn't reduce the positive margin rate. In fact, it doesn't change it at all. Reduce conversion to mastectomy. No, not at all. It doesn't change that a bit. In some papers, they found 3% of women had cancer on the other side. But in fact, I just showed you that really the data shows that only about 2% of women get cancer on the opposite side. Some of that has to do with the fact that we're treating women with medicines that will have an effect on both sides. So Dr. Solon, one of the first groups that actually did breast MRIs at the University of Pennsylvania, looked at lots and lots of women. The local failure rate You'll hear this over and over and over again. Our failure rate in the breast is on the order of 2.5%. This is from the University of Pennsylvania. Their risk was about 3%. And it's really hard to get an MRI to drive that number from 3% to what? 1.5? You're not going to get it to 0 ever. High bar for the MRI. It didn't matter whether you got an MRI or not, the local failure rate was exactly the same. The overall survival was exactly the same. The breast cancer specific survival was the same. The distant disease-free survival was the same. And the contralateral risk of developing breast cancer was exactly the same. The Europeans, and particularly the British, took a good hard look at this. They did a grade 1 trial. 1,623 women. Half of them, they all had breast cancer, half of them got an MRI, half of them didn't. There was no effect on the re-excision rates. In other words, you're not better for getting an MRI. This is the re-excision rates. There was no effect on rate of conversion from lumpectomy to mastectomy. There was a significant increase in mastectomy rates among women who got MRIs, but no change in the size of the cancers. In other words, they just got an operation that was going to make them do any better. And there was what's called a meta-analysis. In other words, you pool all these together. And the meta-analysis showed no benefit to perioperative MRI in the diagnosed patient in terms of overall survival or local control or margin re-excision rates. So there's really no benefit in women who have a newly diagnosed breast cancer. Not to say there isn't a benefit in high-risk individuals. So breast MRI is a key component of breast cancer screening for high-risk patients such as BRCA gene mutation carriers. And I order many of these every year. There is ample evidence showing no impact on clinically meaningful patient outcomes, survival, local recurrence, or positive margin rate. There are lots of negatives. The false positive rate scares the hell out of you. You have to come back. You get more MRIs, you get more biopsies, all of which are extremely expensive, and the increased mastectomy rate. Let's talk about the next thing that's new. Preoperative, and doctors speak, that's called neoadjuvant chemotherapy. Well, the indications in this have been traditionally what's called inflammatory breast cancer. Many of you are aware of that. It basically is breast cancer that's actually diffused to the skin, and there was really no technical way to get all the way around it and cut it out. Large tumors in the setting of a small breast, locally advanced. In other words, these tumors will grow through the skin and involve the skin. But the NSABP, again, looked at 1,523 patients, stage 1 and 2, in other words, did not spread elsewhere in the body. Some of them had lymph nodes involved, and they flipped a coin, and half of them got chemotherapy first, then surgery, or they got surgery, then chemotherapy. And what did they find? And this is the group of patients. You can see a fair number of these patients, but a lot of them got really nice responses. By the way, once again, tumor recurrence is quite low. These curves overlap. These are survival curves. You can see there's absolutely no difference in whether or not your breast cancer comes back or when it comes back. There's no difference in whether it shows up in the lung, liver, bone, elsewhere. There's no difference whatsoever in survival. But what happened was 80% of women got significant tumor shrinkage, and this is an old study. We're now about somewhere between 93 and 95% of women who get preoperative chemotherapy have dramatic shrinkage of their cancer. Dramatic shrinkage of their cancer. 36% had it go away on physical exam, and about a third of those had pathologic complete response, meaning when you looked at it under the microscope, nothing was there. It was all dead. And about 40% had fewer lymph nodes involved at the time of the surgery. So it reduced the likelihood of having bigger cancer in the breast. I won't go into this in great detail, but the bottom line is a lot more women got a lumpectomy. If you had a bigger tumor, bigger than 2 inches, there was a huge increase in the likelihood that you could undergo a lumpectomy. And we had substantially reduced lymph node involvement, which at the time the study was done made these women were less likely to have an axillary dissection and end up with a swollen arm. The other thing we noticed was if you had all the disease go away, in other words, the tumor was dead after the chemotherapy, your long-term survival rate was just terrific, just terrific. So we now use preoperative chemotherapy as a metric for whether new chemotherapy regimens work. And I'll get to some of this in a minute. So the bottom line is, who gets chemotherapy before surgery? Pretty much anyone we know who will need it after surgery. So most of you are aware of what's called triple negative breast cancer. In other words, estrogen receptor, progesterone receptor, and HER2 negative breast cancer. Virtually all of those women will go on to get chemotherapy. If we can feel something on their physical exam, we will give them preoperative chemotherapy. And from a surgeon's point of view, it makes my life a whole lot easier. As I like to tell people, it's a lot easier for me to remove a raisin than a peach. And what we've shown here is doing a mastectomy is not any better than doing a lumpectomy and radiation, even in this group of patients. If they're what we call HER2 positive, and we know that anybody with anything bigger than a quarter of an inch will get chemotherapy, we will give them chemotherapy preoperatively and make their surgery a whole lot easier. And those women who are estrogen receptor positive and lymph node positive, we will strongly consider chemotherapy first as well. I don't want to do what are called lymph node dissections. So one of the major reasons is smaller amounts of disease in the lymph nodes, smaller surgery. One of the other new and really amazing things in breast cancer is what's called genomics. Prior to genomics, virtually every woman who had a cancer over 1 centimeter in size, so over about ½ an inch, and was healthy, got chemotherapy. So somewhere between 85 and 90% of people were getting chemotherapy, and it wasn't going to help them. But we didn't know who that was. So about 75% of women with breast cancer have what are called node-negative cancers, and about 80% of these are estrogen receptor positive, where we know that these little pills are extremely powerful and can treat women with breast cancer very, very well. Chemotherapy improves survival by a couple of percentage points in this group of individuals in these smaller cancers. The problem was we didn't know how to identify who was going to benefit and who wasn't. Well, the Oncotype assay changed all that. So what they did is they looked at 250 candidate genes that were known to be important in the prognosis of breast cancer or progression. And about 16 of these genes are what are called 5 reference genes, which is a nice way to say, yeah, we're looking at genes that have something to do with the breast or breast cancer. And you need those to be sure that you're looking at the right genes. So they actually looked at a group of women who had participated in a prior trial. That trial looked at tamoxifen versus chemotherapy and tamoxifen. And these slides, these what are called blocks, the tissues were actually sitting in a repository so they could pull them all out. And the candidate genes encoded, we talked about some of them estrogen receptors, some of them HER2. And the B14 trial, as I said, randomized women to placebo or tamoxifen between 82 and 88. This is the original group they looked at. We'll get to the chemotherapy group in a minute. And these are the genes. And they were able to identify a group of women who did very, very well. They had what's called a recurrence score. So what you did is you took these genes, some of them were helpful, some of them were not helpful, and you tied a little a multiplicative factor to them. Some were bad, some were good, and you could create what's called a score. And that recurrence score, if it was less than 18, you could see that their recurrence rate on tamoxifen was actually quite good. Intermediate, still good. High risk, not so good. Then they used this assay to look at this group called the NSABP B20, and half of them got tamoxifen. I'm sorry, a third of them got tamoxifen, a third of them got tamoxifen and chemotherapy, and some got tamoxifen and a different kind of chemotherapy. And lo and behold, the people in the low risk group got no benefit to chemotherapy whatsoever. And they were actually a huge group of this patient population. So you can see 51% of the people were in this low risk group. In this group, the intermediate people, they didn't get much benefit from chemotherapy. The only people who benefited were the people in the high risk category. And I'll take it back to what we showed before. Only about a quarter of this entire population, many of whom were going to get the recommendation for chemotherapy, really were going to benefit from chemotherapy at all. So all of a sudden, 75% of women, many of whom were going to get chemotherapy, we basically show that they don't need chemotherapy. And you can see the different risk groups, how they got broken out. I won't go through this in detail, I give you a headache. But these scores started, we put this into routine use, and really only this group of patients were getting benefit from chemotherapy. So how did this work? Well, practically what worked is if the women did not have a pre-existing reason to get chemotherapy, in other words, they had an estrogen receptor positive breast cancer, they did not have a lot of lymph nodes involved, we would send this off and take about 2 weeks for it to come back, and we get a recurrence score. And I would be happy to tell most women, all but this 25%, that they weren't going to get any benefit to chemotherapy above and beyond taking their pills. Now, one of the big problems here is women hear, oh, I have a low risk breast cancer, and about a year into their hormonal therapy, either tamoxifen or the aromatase inhibitors, they would say, well, I really don't like these, and I got a low recurrence score, but I'm going to stop. You can take this whole thing and tear it up if you stop those medicines, because those medicines have an enormous impact on your likelihood of surviving your breast cancer. So a follow-up study was done asking the question, well, what about this intermediate risk group? I won't go into the details, we don't have time, but suffice it to say, in September 2015, the analysis of the low-risk group, again, showed that these women really didn't benefit from chemotherapy at all. The results for the women in the intermediate risk group were presented, and the findings that hormone therapy alone worked as well as hormone therapy and chemotherapy together. After 9 years of follow-up, the disease-free, in other words, walking around without breast cancer, was 83% for hormone therapy alone and 84% for hormone therapy alone with chemotherapy. And for overall survival, the rates were the same. And I'm pointing out how good these numbers are. These numbers, every time a study is reported, get better and better and better. So the bottom line is most women with estrogen receptor positive breast cancer get no benefit from the addition of chemotherapy. There is a group of women under 50 who might get a slight benefit in this intermediate group. I won't go into that today, but we're talking about 3% benefit. Bottom line is we've taken chemotherapy off the plate for the vast majority of women with invasive ER positive breast cancer. Now, this has also been done, by the way, for node positive women with breast cancer. And it turns out you can do a similar analysis even if you have 1, 2, or even 3 lymph nodes involved. And now that whole curve shifts a little bit more, but there's a whole bunch of women now with node positive cancer who are not getting chemotherapy because it's not going to help them above and beyond taking the pills. So we're going to talk a little bit about risk factors for developing breast cancer. I get asked this all the time. So some are really pretty obvious, like female gender. My favorite question to ask my interns is, what's the #1 risk factor for breast cancer? And they usually flail around for a long time before they come across female gender. Males do get breast cancer. It makes up about 1 to 2% of all the people who get breast cancer. Clearly, as you know, increasing age, early menarche, late menopause, no children. In fact, breast cancer in the 1500s was called nun's disease. Older age of first live birth, family history of breast cancer, personal history of proliferative breast disease, particularly atypical ductal hyperplasia, atypical lobular hyperplasia, lobular carcinoma in situ. Women who got radiation for things like Hodgkin's disease. We've talked about genetics a little bit. current or prior estrogen and progesterone hormone replacement therapy. This is actually still remains the #1 controllable breast cancer risk factor in the United States. Turns out that estrogen alone is much less of a problem. But when you combine estrogen and progesterone, the increase in breast cancer is on the order of 1.2 to 3%, 1.3% every year after 5 years. So in women who want to take it for a short period of time, 2-3 years, probably not an issue. But as you take it 5 years or more, you're clearly increasing your risk of developing breast cancer, no question. High BMI, and we'll touch upon that. We know that women who drink more alcohol have a higher risk of developing breast cancer. What's the exact number where it's okay? Nobody knows the answer to that. Imagine doing the study. Lynn, you're going to drink 7 drinks a day for the next 5 years, and we're going to follow it for 20 years. Kathy Kane, you're going to drink 2 drinks a day. You know, Charmaine, you're going to have 1 drink a week, and then you'd have to follow all these patients for 20 years. I mean, you can't do that kind of study. So it turns out most of us say 3 single drinks a week is reasonable. We can debate the size of the drink. So these are the American Cancer Society breast cancer screening guidelines. And you can see the whole point here is annual mammography should be available. Typically, what I tell people is if you have any of the risk factors or you have family history, start your screening at age 40. In women who don't have dense breasts, in other words, fatty replaced breasts, 55 or older every 2 years is probably just fine. So here's one of the problems. We have a terrific screening tool that about 1/3 of our population doesn't use. That's a serious problem. The average size of a mammographically detected breast cancer is about 1/4 of an inch. If you wait till you feel it, it's about 1 inch to 1.5 inches, shaving off about 15% of survival. Big deal, big deal. And you can see this is sort of up-to-date information. You can get all of this on the American Cancer Society website. I would encourage you to go there, cancer.org. It's a terrific source of information. Here's a problem in our society. I do want to make a political statement. Uninsured individuals in the United States do very poorly and account for probably 1/3 of all the reasons that we lag behind most of the Western world in terms of survival from cancer is because of lack of access. So risk assessment. How do you know if you have a risk? How do you know what the risk is of developing breast cancer? There's all sorts of models out there. I won't get into details other than say, who should see our geneticists? Anybody who's got a cancer under the age of 50. Again, I won't get into this in great detail. You can sort of read this, go to the American Cancer Society website. But we routinely refer everybody, lots and lots of people to our genetic counselors. Risk assessment and counseling should really be done through a cancer genetics professional. It is inappropriate, in my opinion, for you to go to your gynecologist who says, "Oh, you got a family history, we'll send off your genetic testing." That in this day and age is not standard of care, largely because when the test comes back negative, what has to happen then is a much further detailed assessment of what the risk actually is. Just because you don't have a known gene doesn't mean you're not at a high risk for developing breast cancer. And that really can be done through a number of computer models, but should be done in an appropriate setting. Just to give you an idea of how complicated this is from the National Comprehensive Cancer Network guidelines. I would refer all of you to these. If any of your friends, neighbors have cancer, just send them to nccn.org. It is a treasure trove of information. And I know that Lynn and the folks at the Pink House will send people there regularly. And if I'm asked, there are only 3 websites worth looking at: nccn.org, cancer.org, and cancer.gov. And then you go to the Pink House. But after that, the quality of the data drops off dramatically. I'm not going to go into this. I'm conscious of the time. And we'll skip to risk. You know what this map is? The trends of obesity in the United States of America. Okay, let's just say red, purple, bad. 1992, 2007. That's how rapidly the prevalence of obesity in the United States has gone on. Another way of looking at it, bit of an issue in 1990, big issue in 2010. This is one of my favorite slides. You can see why this is an issue of concern, at least to this dog as well. I'm going to skip over some of these here. Suffice it to say, regarding lymph nodes, and again, we have really replaced a lot of old-timey stuff, and axillary dissections, which is what causes swelling in the arm, really are not done in 95% of breast cancer patients at this point. This is a major advance in the last 15 years. Vast majority of women who get anything or get what's called a sentinel node biopsy, and the risk of swelling in the arms is about 5 to 8%. Only a small minority of our patients need to undergo an axillary dissection at this point. So I did want to spend a few minutes on what's new. A lot of what is new is addressing the numbers that I've shown you before. We now know that we are vastly over-treating women with breast cancer and have been for some time. The problem is, as I already showed you with chemotherapy, how do you figure out who doesn't need it? So what you'll see here is a list of things that we're currently looking at Levine. And we're trying to avoid radiation therapy if a woman has a great response to chemotherapy. If I take out all the lymph nodes, do they really need radiation therapy if the lymph nodes are all dead and don't have any cancer in them? We avoid axillary dissection in women who even have involved lymph nodes. We know full well from a study that dates back to the 1980s that if you irradiate lymph nodes, even if they're involved, they respond to radiation beautifully. But the thing that's bad is combining full lymph node dissection and radiation. Those women have a 30 to 50% risk of developing swollen arm. So can we avoid that? Can we avoid radiation in women over the age of 70? That's been shown to us. That study, the CALGB 9343 trial, showed many years ago that if you're over the age of 70 and get radiation as well as take the pills which you need to take, the risk of having it come back in the breast is 2%. Well, if you don't get radiation, that risk is 10%. So 92% of women are getting radiation for no benefit whatsoever. And even in the women who it does come back in the breast, I just had this happen last week. She's 12 years out. We took her to the operating room, made a cut about that big, took out the recurrent thing, and off she goes. We are involved in a trial with the MD Anderson Cancer Center, the Mayo Clinic, and the University of Pittsburgh, asking in women who get chemotherapy and had an amazing response. Remember I showed that slide of who gets chemotherapy? Well, if you're looking at women with triple negative breast cancer, fully a half of them, 40 to 50%, when I take out that tumor, it's all dead. Well, do I really need to do surgery to find that out? No. How about doing a core biopsy and then just following up with radiation therapy? In the women who have HER2 positive breast cancers, up to 70% of those women, when they finish their chemo, the tumor in their breast is dead. Do I really need to do surgery as we've been doing for the last 20 years? The answer is almost certainly no, but we need to prove that. In duct carcinoma in situ, which has a death rate of 2%, is treated in 100% of women. We know full well that the vast majority of women with duct carcinoma in situ will never go on to develop breast cancer. So can we figure out who not to treat, who we can just follow? So we are involved in this international study that looks at standard surgery and radiation versus what's called active surveillance. This is not, we forget about you, but we follow you very closely. And we're going to answer the question, who does and who doesn't need to be treated for DCIS. The other very new thing is a lot of this biologic stuff. Well, it turns out that in breast cancer, the therapies we have, hormonal therapy in particular, but chemotherapy as well, work extremely well. So the bar is pretty high for biologics to come along and make a big difference. Wildly different than melanoma, where chemotherapy didn't work. Wildly different than lung cancer, with chemotherapy didn't work. Those have taken enormous leaps forward with these new biologics. But we actually are seeing promise with the biologics in stage 4 breast cancer, and we're now moving some of these to earlier clinical trials. So that was a lot to cover in 45 minutes. But I'm happy to answer any questions y'all might have.
I think everybody's been listening so intently that they haven't written any questions in chat.
Hi, this is Amelia. I do have a question. I'm en route driving, so they want to type anything.
Please don't.
So, Dr. White, thank you for this information. It is very helpful to understand and know what the latest research is showing and finding. As you know, regarding myself and possibly other women, you know, I think I'm kind of an anomaly, especially hearing what I'm hearing today. That's still the case. What kind of research is being done for women like myself who, you know, am not, does not have, at least based on what we know, any genetic predispositions? I was a younger woman when I was diagnosed. I didn't have a reoccurrence, but I did develop breast cancer in the other breast. I didn't have a bilateral mastectomy. I just had a unilateral mastectomy, but did have breast cancer in the other breast. And you may recall, if I'd had a lumpectomy, I may have had to go back later and have the breast removed or something to contend with breast cancer being in a different location of my breast. So I think for me, I mean, I'm always concerned about what are we doing to understand what some of those anomaly situations are, like in my case.
Yeah, I'm trying to grasp the, you know, there's certainly a lot of research going into identifying individuals who are at higher risk, which is one of the reasons that virtually all the things I've talked about, including genomics, including genetic testing, are a major part of our focus right now. The good news is, for the vast majority of individuals, that's certainly not all individuals, we are able to identify risk factors that can help focus follow-up in particular.
Okay, and then to follow up, are you seeing any differences across demographics? So, for example, African-American, or not just African-American, Black women or Black and brown women, are there any differences in terms of risk factors across those demographics, and the differences between brown and Black women, white women, Asian women?
Yeah, and that's a huge part. I didn't have time to go into that today. That's a separate talk in and of itself.
Okay.
We know that there are significant differences in terms of the subtypes of breast cancer for particularly Black women compared to white women. Yeah. And a lot of work is being done to try and address that. Interestingly, we're trying to be more thoughtful and aggressive about screening in Black women, in part because of some of these concerns. So yeah, that's a significant focus of attention and research, and I'm really glad you asked.
Thank you. Yeah, I think that's important. Oh, go ahead. Sorry.
I was going to say, I do have some questions on chat now. Laura Miller would like to know, what is the recurring statistic for triple-negative breast cancer that did not respond well to chemo? And she added that she had an 80% I had 80% residual triple negative breast cancer after chemo first, and then on her post-surgical path report, what is the longer-term risk of it coming back?
Yeah, that's something I would defer to your doctor, because it depends a little bit on what chemotherapy you got, the size of your tumor, your nodal status, et cetera. So I can't answer that in specifics. What I would say is that there's a number of trials that have come out in the last 2 years that show that additional chemotherapy for women with triple negative and HER2 positive breast cancer beyond the preoperative chemotherapy can be of help. And that's exactly the kind of thing you want to talk to your doctor about, because those 2 trials actually demonstrated benefit, which is a big step forward, So I would defer to your doctor on that.
And we have another question. Survivor had her second triple negative breast cancer at Levine in 2009 and again in 2018. She's still looking for answers. She had a lumpectomy in both breasts. And she was told that she's still high risk and wants to know if there's any new hope for her.
Well, again, individual case scenarios are very hard for me to go through in this setting. I would encourage you to speak to your doctors who know your situation in a lot more detail than I do. That being said, as I mentioned, there are ongoing therapeutic trials, and there's also some new information that we just talked about that additional therapies can be helpful in people with triple negative and HER2 positive breast cancer. I would point out, and I'm very biased, that Dr. Antoinette Tan of our group, I'm the surgical director of our breast program. She's the medical director of the breast program, is one of the world's experts in triple negative breast cancer, has actually written a textbook regarding triple negative breast cancer, and is heavily involved in a number of research trials nationally. So we do have some great resources here in town as well.
We have another survivor who wants to know how you feel about taking an anastrozole for 5 years versus 10 years.
Yeah, again, that's an individual discussion with your doctor. There is clearly evidence that 10 years is better than 5 years, but that's a very incremental benefit. And there's a lot that goes into that decision making, including how you doing on it. I mean, if you're doing just great and your bone density is fine and you're relatively high risk, then it makes perfect sense to take it for 10 years. If on the other hand, you're having some bone density issues and some toxicities associated with it, and you're at 5 years and you're relatively low risk, that's the other end of the spectrum. So that, again, is a fairly lengthy conversation with your medical oncologist about the pros and cons of doing that. There's actually some nomograms and ways to calculate risk that are out there now as well.
Okay, we have a stage 4 metastatic breast cancer patient. When did the study come out recommending chemo before lumpectomy? And also, what is the protocol pertaining to MRIs after initial lumpectomy or mastectomy for high-risk cases?
So let me answer the second question first. There is no evidence that doing an MRI after you've had your interventions for your cancer is going to make you do any better at all. There's no benefit to doing it prior in most people. Again, there are exceptions that I talked about, but there's equally no evidence whatsoever that says that getting an MRI afterwards is helpful, with significant exceptions. Those people who have genetic mutations who actually put them at an elevated risk of developing breast cancer on the opposite side. So if you're a woman who has a BRCA mutation who elected to have a lumpectomy or even a mastectomy but preserve your opposite breast, that's exactly the person who should have an MRI on a regular basis. Neoadjuvant chemotherapy has been looked at since around 2000 and is becoming more and more utilized as time goes by. Remember, there is no survival benefit necessarily to doing neoadjuvant chemotherapy. In other words, chemotherapy prior to surgery. The benefit comes in less surgical interventions and both in the breast and in the lymph nodes, hopefully sparing a lot of women a swollen arm. I don't know if I answered that question precisely.
We have another question here. A survivor was part of the Alliance trial. She had neoadjuvant chemo and axillary node dissection. She understands that they are not doing that Alliance trial anymore. Do you know why?
No, the Alliance trial that I just showed reopened about 3 weeks ago.
Oh,
So the
okay.
trial has been expanded and it is ongoing.
So will they include me back in there, or will they not?
Nobody ever got taken out.
Oh, okay. I haven't heard from anyone.
All that happened was we went from, and I'm doing these numbers off the cuff because I don't remember them, but went from like 3,100 to 4,600 women who are going to be in the study.
Okay, thank you for that information. I guess I'll hear from the folks then.
Yeah, and your research coordinator who's following you shouldn't have told you anything because it was actually not closed. It was just put on hold for about a year.
Put on hold, and that is my fault. My radiation oncologist had told me it was put on hold at the time because I turned up with some lymph nodes that still had cancer in them after my deep flap. So I was wondering why they hadn't called me back. So that was my bad on
Any other questions? I'm going to need to step off here in about a minute or two.
I have a question that I think you can answer in these last 2 minutes. Donna Shaver had cancer in both breasts, but 2 years apart. She's pretty sure that the MRI just didn't see it in the right breast. She's just wondering what your thoughts might be on that. And you might not be able to answer that since it's a personal.
Yeah, we live in a society where technology is king. When I go to get my colonoscopy, Tom Pacheco did my colonoscopy, did not say, Richard, you don't have colon cancer. What he said is, I didn't see anything. So a negative MRI and a negative mammogram are just terrific, as is a negative physical exam. It doesn't mean you don't have breast cancer. What it means is that the test didn't identify it. And that's I think we all understand that. But we struggle with proving a negative. As I say in my clinic all the time, the hardest job I have around here is trying to prove somebody doesn't have something. I don't know, for example, I don't have prostate cancer sitting in front of you right now. I don't know that I'm not going to be diagnosed with a brain tumor in 6 months. So the good thing is our technologies are the best that mankind has ever known. And in fact, we're running into technologies, the MRI is a little bit like a PSA test. We can find stuff, but it may or may not have any clinical implications. So the good thing is we're certainly in a very enviable position. I mean, I've been around long enough, and one of the major changes that I've seen in my career is that the vast majority of women that I see are going to do beautifully from their cancer. When I started, most women actually were afraid to die. And now most people have the opportunity to live. So I'll conclude on that.
That's a very positive note.
Well, thank you all for the opportunity to talk to you, and thank for everything you do for Christie's Pink House.
Oh,
Thank you,
thank
Dr.
you so
White.
much.
Thank you.
Thank you.